Hello, I am Karen Bravo, an internal medicine resident from the University of Miami, and today I am presenting a case of chronic active Epstein-Barr virus infection. This is a disease described as a rare disorder, progressive, with high mortality, which was initially described in 1984. This is characterized as chronic or recurrent mononucleosis-like symptoms accompanied of an elevated Epstein-Barr virus copies. This condition is as rare as that maybe only one between 1 million of people who develop Epstein-Barr virus are going to get this complication. The patients may present with fever, lymphadenopathy, splenomegaly, hepatitis, or pancytopenia. But over the time, these patients develop progressive immunodeficiency and complications of leukemia, lymphoma, and high cytokines cascade, which is the reason of the high mortality. So let's go to talk about my patient. She's a 61-year-old African-American female with a medical history significant of HIV with a undetectable viral load over the last 8 years and hypertension. She presented with ED, complaining of worsening dizziness and generalized weakness. She states that over the last 1.5 years, she has been presenting intermittent episodes of fatigue and no quantified fever and this weakness. However, the severity over the last week was so getting worse, so she decided to come to the ED. Initially, she was found hemodynamically stable. However, the lab work was significant for severe thrombocytopenia. The platelets were 20, accompanied of microcytic hypochromic anemia. The hemoglobin was 9.2, compatible with anemia of chronic disease. Also, the reticulocyte count index was low, suggesting a bone marrow hypoproliferation. Further workup included like hemolysis panel, which came back positive, and also a blood smear, which shows some schistocytes and sickle cells, also accompanied of 3% of metamyelocytes. On the physical exam, it was evident the hepatosplenomegaly, so we ordered a CT of the abdomen to confirm these findings, and yes. But in addition to confirm the hepatosplenomegaly, it also shows some changes on the density, especially on the spleen, suggesting a lymphoproliferative disorder. At this point, we had high on the differential, these kind of disorders, but also TTP as well as HPN. Later, we ordered panel for this condition and resulted negative. Because this patient presented with mononucleosis-like symptoms, we ordered a panel of Epstein-Barr virus and cytomegalovirus. There was no surprise when we find like this panel compatible with chronic disease. However, when the Epstein-Barr virus DNA came back elevated, then we opened a differential and we found this CABB disease. And let's go to talk about this a little bit. The pathogenesis of Epstein-Barr virus is very well known for the carcinogenesis of this virus. However, in this condition, T and natural killer cells are affected, as well as B cells. B cells are affected mostly on the American population, which is the second most common presentation, and the first most common presentation involves T cells and natural killers on Asian and Hispanic population. About the criteria for the diagnosis of this condition, they were established in 2005. We have had some changes, but are basically illness lasting more than 6 months. Now that was updated to more than 3 months. Infiltration of tissue with lymphocytes as the bone marrow, as we can see on the imaging, elevated Epstein-Barr virus DNA, RNA or proteins in affected tissues, and the absence of any other immunosuppressive condition. In my case, we know that my patient has been with viral load undetectable. The sooner that we get the treatment, the better the overall survival. Usually, the treatment for these patients is allogenic hematopoietic stem cell transplant, and with this treatment on mild to moderate disease, the overall survival is 76 to 90%. However, when we have already a fatal complication, the survival is only 20%. Children and adolescents with this condition mostly die within 5 to 10 years, and the progression of adult onset is even worse, twofold faster. This is why I'm presenting this case and why every doctor has to have it on the differential. Thank you so much.